Thank you, Dr. Moin, for your kind introduction. And I am thankful to the Pakistan Academy of Family Physicians for inviting me to give a talk here about diabetes and Ramadan fasting. It is, a very common problem, and Alhamdulillah, with the blessing of Allah, actually, I actually worked not only in UK, but also previously I worked in Makkah, Saudi Arabia also, and UAE. So I saw their traditions as well, and obviously I am from this country, so we know, so I will try to share my experience as well. So, inshallah, and you can ask any question at the end, So I think because of the shortage of I think I have got 20 minutes, so I will just, focus on the main points which we need discussion and which you need to know actually. And these are my references. Now about the epidemiology, I already Fauzia Moin mentioned. There were approximately 463 million people with diabetes in the world, with 1 in 2 adults are undiagnosed. So, and this total number is predicted to rise 700 million, 10.9% by 2045, with a 50% increase in diabetes. So there are estimated 1 to 1.5 billion Muslims worldwide, comprising 18 to 20% of the world population. Prevalence of diabetes worldwide is about 4.6%, and obviously it is very high. Pakistan comes on the top countries. EPIDAR study, Epidemiology of Diabetes and Ramadan study, conducted in 2001, and in which Pakistan was also part of it. Where they studied more than 12,000 people, and 43% they came to know that 43% of type 1 diabetes and 79% of type 2 diabetes fasted during the month of Ramadan. So estimated 40 to 50 million diabetics worldwide, they fast during the month of Ramadan. Ramadan, we all know that it's an Islamic lunar month. Its duration varies from 29 to 30 days, and timing of fasting period changes with respect to season and geographical location. And duration of fast may vary from a few hours up to 18 hours. People who fast must abstain from eating, drinking, smoking, and taking oral medication or IV fluids from pre-dawn till after sunset. Most people consume 2 meals a day when fasting. Evening meal after sunset is called iftar, and pre-dawn meal is called sahur. Quran specifically exempts the sick from fasting. So diabetics fall in this category of sick people. But obviously those who are well controlled, they wish to fast, and they do fast, But fasting is quite common among Muslim diabetics worldwide, therefore it is a global medical issue. So what is the pathophysiology of fasting in a normal individual? Normally after intake of food, blood insulin level rises. During fasting, blood glucose falls, resulting in reduced insulin level. Reduction in blood glucose levels leads to increase in glucagon and catecholamines levels, promoting glycogenolysis and gluconeogenesis, which stops further fall of blood glucose levels, resulting in maintenance of blood glucose level within the normal range in a normal individual. Several hours of fasting leads to depleted glycogen stores. Reduced insulin levels leads to increased free fatty acid. This leads to increased ketone bodies, and ketone bodies provide fuel to skeletal and cardiac muscles, liver, kidney and adipose tissues, sparing glucose for continuous utilization by brain and erythrocytes. In diabetic patients, pancreatic beta cell function is impaired, and obviously this results in impaired insulin secretion. Glucagon and epinephrine secretion may fail to augment properly, which in a normal state helps to control the fall in blood glucose levels. Moreover, diabetic patients are either under the influence of oral hypoglycemic agents or using insulin. Therefore, if medicines are not adjusted, then chance of hypoglycemia increases in diabetic patients. In patients with type 1 diabetes, who have got severe insulin deficiency, a prolonged fast in the absence of adequate insulin can lead to excessive glycogen breakdown and increased gluconeogenesis and ketogenesis. This leads to hyperglycemia and ketoacidosis. Patients with type 2 diabetes may suffer similar problem of hyperglycemia in response to prolonged fast. However, ketoacidosis is uncommon and severity of hyperglycemia depends on extent of insulin resistance and or relative insulin deficiency. So what are the risks associated with fasting in diabetic patients? Is the hypoglycemia can occur, hyperglycemia can occur, diabetic ketoacidosis can occur, and dehydration and thrombosis, they predispose to it, Hypoglycemia accounts for 2 to 4% mortality in a patient with type 1 diabetes. This is normal, not during Ramadan, And hypoglycemia is an infrequent cause of death in patients with type 2 diabetes. There are no reliable estimates concerning contribution of hypoglycemia to mortality in type 2 diabetes. In EPIDR study, following observations were made. 4.7-fold increase of severe hypoglycemia in type 1 diabetics and 7.5-fold increase of hypoglycemia in patients with type 2 diabetes. Now, what are the hyperglycemia? Various studies have shown that the control of glycemia in patients with diabetes either deteriorates, improves, or shows no change. In EPIDR study, 5-fold increase in the incidence of severe hyperglycemia requiring hospitalization was seen in patients with type 2 diabetes. And 3-fold increase in the incidence of severe hyperglycemia without ketoacidosis was seen in patients with type 1 diabetes. What were the possible causes of hyperglycemia? Excess reduction in dosage of oral hypoglycemic or insulin, high intake of food rich in carbohydrate and fats and sugary drinks at iftar and sahur, and lack of adequate exercise can also contribute to hyperglycemia. And what are the possible causes of DKA? Diabetic ketoacidosis, increased risk of, if there's a poor control of diabetes prior to Ramadan, then the excessive reduction of insulin dosage with the assumption that the food intake will be reduced. Untreated infection can lead to hyperglycemia and diabetic ketoacidosis. And presence of infection requires increasing presence of infection requires increasing insulin dosage by 10 to 20%, plus appropriate treatment for the underlying cause to avoid hyperglycemia. So what are the possible causes of dehydration in these cases? Not taking enough fluid during non-fasting period, prolonged duration of fast, especially in the summer, working in hot and humid environment, and hard physical labor leading to excessive perspiration, poorly controlled diabetes that leads to hyperglycemia, which can cause osmotic diuresis resulting in volume and electrolyte depletion. And this may cause orthostatic hypotension, especially in patients with autonomic neuropathy and elderly, which may lead to syncope, falls, and fractures. And patient with diabetes normally exhibits a hypercoagulable states in general, because if they have got poor diabetes control, because of increase in clotting factors, reduction in endogenous anticoagulants, and impaired fibrinolysis. Contraction of intravascular space further contributes to hypercoagulable state, increasing the risk of thrombosis. A report from Saudi Arabia suggested increased incidence of retinal vein occlusion in patients who fasted during Ramadan. But however, hospitalization due to coronary events and stroke were not increased during Ramadan. But I have personally not experienced, this kind of situation. But anyway, there was one report, so it is worth mentioning, This rare complication can also occur. So what are the factors that may influence the development of personalized care for people with diabetes that fast during the month of Ramadan? So Ramadan-related factors are length of fast, season of fasting, weather, geographical location, social changes, and past experience. And what are the diabetes-related factors? The type of diabetes, is it type 1 or type 2, duration of diabetes complications, if they've got like nephropathy or something, anti-diabetic drugs, and previous control. If it's a good control, then it's easy to fast actually. Proneness to hypoglycemia and hypoglycemia unawareness and access to care. Yes, medical care and advice is available to the patient or not, that's also important. And factors concerning the individual, age is very important, especially elderly, gender, female or male, occupation, pregnancy, lactation, meal pattern, exercise, and motivation and personal preferences. These are the elements for risk calculation and suggested risk score for people with diabetes mellitus that seek to fast during the Ramadan. If you are more meticulous, yes, you can do this kind of calculation also. And obviously, they have given the number and then score from 0 to 3 is low risk, from 3.5 to 6 moderate risk, and more than 6 is high risk patient. Now, who are the patients who are advised not to fast? All sick patients who are ill because of any problem, they should be advised not to fast. All brittle type 1 diabetic patients, poorly controlled type 1 and type 2 diabetic patients, patients known to incompliant in terms of following advice on drugs, diet and exercise, patients with serious complications such as unstable angina, heart failure, uncontrolled hypertension, pregnant diabetic patients, elderly patients who are frail and or have any degree of alternative problems, and patients with established renal failure. That about the pregnant diabetic patients, I can just share my experience in UAE and Saudi Arabia. Many diabetic patients who are pregnant, and they come and ask us to adjust their medicine so that they can fast. And it is common here, but not in our country, but it is common there. And I think the people who are like GDM, gestational diabetes, oral hypoglycemic agents, or small doses of insulin well controlled, and they used to fast with drug adjustment, and normally we did not experience any problem unless we do a formal multi-center study in this regard. It is not advisable to give any recommendation on that, So patients in high-risk categories, patients with type 1 diabetes, type 2 diabetes on insulin, elderly patients living alone, patients with hypoglycemia, unawareness, and patients with comorbid conditions such as uncontrolled hypertension, ischemic unstable, patient with ischemic heart disease, heart failure, and renal failure. Low risk categories, all well-controlled type 2 diabetic patients, diet-controlled patients, oral hypoglycemic agent that come in the above category, and patients who accept and obey medical advice regarding diet, drug adjustment, exercise, and close monitoring, especially during the initial days of Ramadan. So whenever the patient comes to you and asks that, what should I do and how I adjust the medicine, you tell them to adjust, tell him the initial few days, he should check more frequently, the blood glucose levels to make an eye on that he does not get very high or low levels. It is also important to mention here the decision to fast is an important personal decision, should be used in line with the religious exemption. Patients should adhere to recommendation given by healthcare professionals to experience safe fasting, and patient must be aware of associated risks involved. And care must be highly individualized, and blood glucose should be monitored frequently before, especially in the initial days, just to check everything is going fine. Before sahur, at midday, 12 p.m., before iftar, and 3 hours after evening meal. The blood glucose monitoring could be done by manually or continuous glucose monitoring system, CGMS, flash glucose monitoring system like Freestyle Libre, and obviously it is expensive. And use of telemedicine, online consultation, SMS, WhatsApp, video consultation, etc. can be used to monitor the patient and giving advice. I think this is more commonly used now after especially the corona virus came, The diet should not be different from the taken before Ramadan. 2 to 3 dates could be consumed at iftar. Various studies have shown that during Ramadan, 50 to 60% of patients maintain their body weight, while 20 to 25% either gain or lose weight, and occasionally weight loss may exceed 3 kilogram. Avoid large amount of food intake rich in carbohydrate and fat, especially at iftar and sahur. Increased fluid intake during non-fasting hours, and pre-dawn meal should be taken as late as possible. Light to moderate exercise 2 to 3 hours after iftar. Avoid strenuous physical activity during the daytime, especially afternoon, as it may predispose to hypoglycemia. For some patients with poor control diabetes, exercise may lead to extreme hyperglycemia. Tarawih prayer could be part of exercise regimen. So what are the recommendations regarding breaking the fast? If the blood glucose falls below 60 milligram per deciliter, anytime, and if blood glucose level drop below 70 milligram per deciliter within few hours of fast, with insulin or oral hypoglycemic agent that contains sulfonylurea. If blood glucose levels exceed 300 milligram per cent, and avoid fasting on days when feeling sick. So what are the pre-Ramadan medical assessment and education is important for all patients who are coming to you for regular follow-up and who wish to fast and who are diabetic, So you have to give, advice regarding blood glucose monitoring, meal planning, physical activity, and how to adjust the medicine during the Ramadan period. And adequate nutrition and hydration is important. So what about in type 1 diabetes? I think that twice daily NPH or medium-acting insulin at iftar and sahur, and short-acting insulin to cover food at iftar and sahur. Obviously, preferably we use ultra-short-acting insulin like Aspart, Lispro, or Glulicin. If somebody is taking mixed-start insulin before Ramadan, 30 in the morning and 20 in the evening, then he can take that morning dose at iftar time, and evening dose at sahur could be reduced by 25 to 30%. So another option is to use a long-acting basal insulin like Insulin glargine, insulin deglutec, insulin detamere also. Once daily at iftar and twice daily as before, and we use ultra short acting insulin at iftar and sahur. People who are already on the continuous subcutaneous insulin infusion pump can maintain their basal level of insulin while fasting and can take boluses of insulin at iftar and sahur. So I think the insulin pump, they are quite good actually in these kind of situation. In somebody is using it. The pumps are expensive and still require frequent blood glucose monitoring, but it could be they have the system that they can check the blood glucose, in CVMS. Patients with diet control, there is virtually no risk of hypoglycemia unless patients indulge in undue exertion. There is a risk of postprandial hypoglycemia after sahur and iftar, so advise regular exercise and adequate fluid intake during non-fasting period. The patient on oral hypoglycemic agents, there is a low risk of hypoglycemia with drugs that increase insulin sensitivity like glitazone and metformin. If using metformin, 2/3 of the daily dose at iftar and 1/3 at sahur. Glitazones have low risk also, and normally given once daily. Sulfonylurea, there is an increased risk of hypoglycemia. It's used with caution in newly diagnosed patients. And use of chlorbromide is avoid glibenclamide. Gliclazide is better tolerated. And should I stop or just finish? I think it's 2 minutes. 2 minutes. Yeah, 2 minutes, okay. Yeah. Prandial glucose regulator like ripaglide and nitaglide, they are good. DDP4 inhibitors, I think the ones, now we have got once weekly DD4 inhibitors also. Patient treated with insulin, type 2 diabetics, as like with type 1 diabetes, this risk of hypoglycemia is there, and obviously dose has to be adjusted. So I think these are the various combinations, so I will not go into details. Hypertension also, again, I think you may need the morning dose reduced, and the iftar time you give more doses, Renal impairment, obviously the mild one, it's a risk, the patient should be aware that his kidney function can deteriorate, and, his condition might get worse, and unless it's a mild one. So patient with the renal impairment also, and patient with heart disease and ischemic heart disease, if they are well controlled, yes, they can fast. And thank you very much. Any questions?